Hi, everybody. Welcome to the Genius PT Project. This is the third segment of our talk with Mike Stewart on the education of pain, or pain education, the challenges and the pitfalls. We recorded 2 sessions earlier that you can find on our YouTube channel as well as our website, www.thegeniusptproject.com, where we introduced the topic in the first one. And the second one, we actually, Joletta, Carolyn and I interviewed Mike, and he was gracious enough to come on and share so many pearls of wisdom about pain and pain education. So we're here today to allow all of you to join us with Mike and ask your questions. If you haven't had a chance to listen to the earlier ones, you can always go back and have a listen and let us know your comments at any time. So, Mike, thank you for joining us all the way from the UK.
Pleasure. Absolute pleasure.
I think it's 7 o'clock your time. It's 3 o'clock my time. It's probably different times for everybody, but we're all thrilled to be here for some social engagement as well as learning a few things today. So, Carolyn, I'll let you kind of start it off, and we can open up with questions. Or did you have something you wanted to do in the way of a introduction or a topic here?
You know what? I'm going to open it up to the floor first, because we've had a chance to ask Mike some of our questions. And so I'm just going to open it up to ask anyone who has a question for Mike to go ahead and unmute yourself and ask your question. If no one has a question, I certainly do. Is anybody going to be brave and step forward? I know it's always hard to be the first person to unmute yourself. Everyone's watching and looking at me. Okay, let me ask my question, Mike. We are clearly in unprecedented times, right? So this is a time in the world like we've never seen, like we've never imagined that we would see, actually. I think I can speak for myself and many people certainly here in Canada. And I know that in Canada, one of our struggles continues to be in physiotherapy, that there has been this lack of uptake of pain education for patients. And yet here we are facing a real challenge to our clinical practices, in that what we do primarily as physiotherapists is educate our patients. And we may find ourselves in a position where we lack the skills to really effectively move into telerehab, with not having maybe the background behind us either in pain education or just education in general. Do you have any suggestions around where we might start if this is a starting point for us?
I'd agree. I think these are obviously clearly unprecedented times, and I think for those of us who have invested time and energy into developing these power skills, we're not going to call them soft skills, remember? Mm-hmm. For anybody who's been acknowledging the importance of these techniques, these ideas, these skills, now is the time that I think they're really going to come into their own. And I think, we have to sort of see opportunity in this. I think this is a really sort of quite easily could be a very pessimistic time. Mm-hmm. We spoke last time about turning the focus on to looking at solutions, not problems. So in a sense, as horrible as this situation might be, I suspect that for lots of clinicians, they will have to skill up very quickly. So my main piece of advice is listen more than talk. Even if maybe a good thing to do from your own perspective is to record, get your patient's permission to record your consultation and listen back to what percentage of time you speak. See if you can enable the patient to speak more. If you're talking more than they are, there's something wrong. So we often talk about listening. The evidence shows that we're not particularly good at it, even though we often assume we are. So an easy way to check if you're listening more than talking is record. You're going to have it on your Skype consultation. Mm-hmm. Record it, analyze it. How much do you talk?
Excellent. I think that's great advice. If someone really is struggling with even just the nuts and bolts of pain education or understanding that the pain system a little bit more, where would you point them? What resource would you send them towards if they're at that starting point?
If they really don't know, anything, if they're right at the beginning with this, I'd say the best places to go looking would be Noy does some great stuff,
Mm-hmm.
of course. So I'd be looking at anything that David and Lorimer have produced. I would be looking at any of Peter O'Sullivan's work. So I'd be looking at pained.com, I think is a great place to look. I have on my website, we have a number of sort of resources. So there's a whole resource page. What we've tried to do over the years with our website is have a resource page full of narratives from patients, people living with pain. So listening to other people's stories, finding validation through other people is really, I think, especially at a time like this where social bonding is lacking, that could be helpful. So head to nopain.co.uk. You'll find a whole range of things to listen to, things to watch, things to read, both from people who've lived it and people who are trying to help people living with it.
Excellent. Okay, that's a great place to start.
Perhaps, Joletta, you could, if you wouldn't mind bringing some of your brilliance to the table from your perspective as well, since Mike talked about looking and listening and connecting with other people that are going through very similar, journeys. And you certainly have been through the journey and have, a lot of advocacy that you deal with as well, too. If you could, bring some perspective to the table, I think that'd be great.
Yeah, and I had a question that I was going to jump in and ask Mike that I think will fall in line with that. That's totally in line with my biases and the way that we frame this as education. Yet and that it's patient education, but that the advice is to listen and to really allow the person that's in pain, the person that is seeking care, to share their story, their questions, their worries, and let that guide the discussion. So is the way that we frame it as patient education perhaps misleading, where people then feel like they have to lecture or provide information to and still do to the person rather than have a conversation with and explore with and do things with the patient or the person that is seeking care instead? So curious as to your thoughts on that.
It's a great point, and it's back to that discussion that we had last time we chatted, which is, I think people have a misunderstanding about what education is. Education, I did my master's degree in education, and the thing that really struck me and that everybody really needs to take home from this is education is about drawing out from people, not pouring in. So you cannot educate somebody when you just talk at them. People stop listening. It's very easy to go down the sort of lecture road. Physios particularly, as a profession, we were set up to fix problems. We're problem fixers. And it's an issue because people don't get better when we try to fix their problems. People start getting better when you enable them to open up, to express their experience, to talk about it, and then to try and turn the focus towards solutions. But I always think there's three rules with guiding somebody. Listen is the first thing. Only by listening can you do the second thing, which is find out what they need. If you listen, you can then find out what people need. And of course, every person's going to be different. Then you can do the third thing, signpost them. So it comes back to our chat just now, Carolyn, about where can people go and look. Listen, find out what they need, signpost them. If you think in those three, it's much harder than that in reality, but as a framework for guiding people, that's the way to do it. The more you talk, the less people are going to start to keep that information. It's got to be based in experience, their experience, not yours. And it has to be based in a mutual understanding, a shared consultation, a shared narrative, not just you talking to them.
Nicole, go ahead. Yes.
I have a question, if that's all right, or somebody else.
Please do. Yes.
So I don't know if I'm going to word this correctly, but when we're in clinic and we have a client who's in persistent pain and we start that discussion, sometimes we are doing that in the midst of doing a hands-on technique at the same time, sort of coming at it because they're maybe not ready to accept that discussion yet or that talk, and or I find sometimes a lot of clients come in with an expectation that because we are physiotherapists in the traditional role, or what they assume the traditional role of a physiotherapist is, the doing something to them, hands-on stuff. So, even when I have that discussion with people and, we have 25 minutes and we've been discussing pain and we've talked about it, blah, blah, and then they're sort of like, there's 5 minutes and they're like, okay, so what are you going to do to me? So I guess, I still struggle with that bit, and I wonder, how I'm going to elicit a clientele to come onto the virtual platform and just listen to that as well. I guess I struggle still a little bit with that.
Yeah, it's a really good point. Personally, I've found over the years, for me as a clinician, I ask people before they come in for the first consultation. I send them an email, I drop them a phone call, and I say, look, could you write down a list of things that you want from this? What are we make wish lists.
Mm-hmm.
What are your wishes? What do you want to get from this? And any questions that you have, can you write down some questions that you might have? I think that's a really good to start having that conversation. At the moment, obviously, there won't be physical contact. So it's going to really sharply turn the focus towards the skills that we're discussing. But I think even under normal circumstances, when you're seeing somebody in clinic, I think if they come in with a list of questions, a list of desires, a list of wishes, you can then as a clinician start having that conversation. Well, let me go through what I can do to help you to overcome this. We have this. And then I tend to go through with people, take me through what you've tried before and what's worked or not worked. And often what you tend to find, especially with patients I see who've been round this roundabout a lot, is they suddenly work out that actually I've tried the hands-on technique and it was itch scratching. It felt nice for a bit and then it keeps returning. So it's looking for more, like we spoke in our last chat, about the idea of almost the driving instructor. Mm-hmm. We have to see ourselves as a driving instructor.
Yeah, I still like it. I'm totally there. I've had a couple of clients where they're very obviously it's not the hands-on, because they've done that. They've done it with multiple different clinicians, and then you start down that, we've gone down that road, and I guess maybe I don't know, they still want the hands-on. And even though I just say, well, how is that, how have you done so far with that process, and are you willing to look at it from a different venue, and can we just try this and experiment with this, and let's just try this different way because you haven't, and see where it takes us. And they end up not coming back. But I guess there's a certain population that maybe they will eventually trying and nothing works. So
in a way, is that such a bad thing? I would argue that, if they're not coming back, I mean, from a motivational interviewing perspective, essentially what you're discovering is that they're not ready. And if they're not ready, I mean, Schumacher said, if people don't want to be helped, leave them alone, because we'll make it worse, not better. Andy Warhol once said, when people are ready to change, they change. Sometimes they die before they ever get round to it. So if they're not quite there, I mean, I've developed a sort of a way of being in practice, which is I will try my best to turn somebody towards self-management, behavior change. But if they're not ready, then they know where my phone is. They know where my email is. They can contact me when they're ready. I'll share just one story. I had a guy once who came to see me who worked in a clothes shop. And he said, if you have to give me the massage, if I came into your clothes shop, I would give you the purple T-shirt with the collar. You need to give me my product. It's not that. We have a professional and moral duty to say, actually, what the evidence points towards is that these are the best things for you. If you want to carry on with massage, do it somewhere else. But the least we can do is to sow the seed. And then maybe 6 months, a year later, you'll see that person back and then they're ready. Maybe.
I think as well, Nicole, I think that's a really great point. And I guess maybe what I tend to do in my practice at this point is kind of that same concept of test retest. So if I sort of talk to them about, they believe let's just talk about pelvic floor for a sec, because that's what I predominantly see. But let's say they have tension in their pelvic floor, and we note that on physical exam, rather than me going in to fix that, whatever that means, right? I might engage them with doing something more self-directed. We might choose a yoga program or a qigong program or something that they are going to be engaged in. And then I'll say, well, let's just test out what would happen if you did this every day for a week. Would we notice that overall there's less tenderness in your pelvic floor? Would we notice overall that there's a change in your pain? So it's really, empowering them to note the changes, but you have to have them sort of be really primed on what it is that they expect to change as a result, and whether it's a functional activity, whether it's pain, whether it's tension, whether it's whatever it is. I think our hands play a role, but we can also say over telerehab, everything in your history suggests to me that that you're guarding that area, and that may be contributing to your pain response. Let's work on things that you can do to change that guarding. And sometimes it's understanding pain, sometimes it's moving in a different way, but it's still their journey. I don't know if that helps. And I know you do that. I know that's not new news for you, but I think that telerehab is going to give us an opportunity to actually see what our patients are capable of, and we'll give our patients an opportunity to see what they're capable of if we tend to really use our hands a lot.
It's a really good point. All of the evidence points to the fact that clinicians tend to be, by their very nature, quite paternalistic. We want to protect, we're healthcare providers, we care for people. And sometimes, particularly in physiotherapy, we sort of kill with kindness. We care too much. So I think you're right, Carolyn, that this is it's a terrible situation the world finds itself in, but what a great opportunity to see if people can start to cope independently and with some guidance from us. And I've been seeing patients online through Skype consultations for years. And I said the other day on Twitter that I find one of the weird therapeutic gains is that actually people open up a lot more when there's a digital distance. Some people find it really hard to talk face to face in the same room. So you might find actually that it's easier for people to start talking more.
And again, we're movement specialists, so we can get people to move really nicely at home. I've been finding, and again, I've been doing tele-rehab for years as well, but I have found, as I'm doing more and more of them this week, that seeing them in their own environment, seeing them move in their own environment and do things in their own environment gives you a whole other perspective on what's going on with them than if you see them in your office, which is quite artificial, actually.
Yeah. With that in mind, here's something you could try with your patients. I mean, it's a simple, remember, start with that question, do you mind if we try something? Always a great question to pique curiosity. And then say, look, I can see you in your house on your screen. Could we play a game? You have a home gym, this chair that you have, this wall that you have, the floor that you have. Can you show me how many movements, how many fun movements, how many exercises, whatever you want to call it, can you produce in 1 minute? Can you try this now? And then the conversation is about, great, look at what you did there. You've got a video recording of it. How will that help you? The 3 rules of exercise are meaning, meaning, meaning. So if somebody creates a sit to stand from the chair, or they create a press up against the wall, then start to ask them, well, how is that going to help you do the things that you want to do? How's that going to get you back to playing with your kids, or whatever their desire is? So it can be personalized to that individual, but make people realize that creativity is a key thing, especially at the moment where people are trapped inside and they need to discover how their house is now suddenly a gym.
Can I add one thing too to Nicole's?
Please do, Joletta. Yes, please do.
And again, coming at this from the biased patient perspective, I want to be careful with language and saying, when we're talking about readiness to change, that's very specific for them changing in the way that you want them to. So it's very specific to that context. And a lot of times patients are coming in and just having their narratives replaced by the clinical or the medical narrative. That what you are thinking, what your story is wrong, and I am now telling you what the right one is, and this is the path that you should go down. So that's going to be met with a lot of resistance. And we've talked in one of our earlier series, and I can't remember which one it was. I think it was with Shelley, that when you meet that resistance, rather than pushing against it, to use that as a point of becoming more curious about why that resistance is there, and starting to ask more questions they have those expectations and those beliefs for a reason. So exploring those a little bit deeper might open up the conversation in a way that starts to lead them down a path that you would like them to go down. But that has to be a shared path. It can't just be, this is what I want you to do because this is what evidence says. They're not just going to come on board with that, because that means when it comes back to meaning, that doesn't mean anything to them. It doesn't mean anything to the life that they live and the person that they are and the person that they want to be. And discovering more of those things might open up possibilities to approach that conversation and approach that path forward in a different way. One of the things that frustrates me the most is when I hear things like patients aren't motivated or they're not ready. That's very specific to what you want them to do, and it's not specific to what they want to do. And finding out those things could lead down a different path.
My biggest bugbear as a physio is if I had a pound for every time I hear somebody say, this patient didn't do my exercises. And I'm like, yeah, there's an issue in there. The word my exercises, you didn't do my exercises. The idea of adherence to your exercise, it's paternalistic. It's it's clinician led. It's driven by the clinician. I think practice becomes far more effective and far more fun for both us and people we see when they take ownership. When you can give them ownership and empower them quickly to realize that they have the skills. You just have to draw it out from them. Again, education is about drawing out, not pouring in.
I love that, especially because I've talked to a lot of people who are living really well with pain or recovered from pain. When you ask them about how they got better, not one of them has ever answered like band walks or clamshells or glute bridges. Mm-hmm. Those never come up in the conversation.
No. I think it's really important. I mean, one interesting way that I tend to try and get people to think is, imagine if your brain is a company. This is the boss here, and you've got all these other departments throughout the body. So if you take back pain, for example, that back department has been underperforming. It hasn't been hitting its targets for a while. So your boss needs to see some targets are being hit. So that means, record yourself on your phone doing some movement, doing some exercise. If the retinas see it, the boss sees it. And Patrick Wall once said years ago, ongoing pain is less about damage and more about the brain's opinion of the body part. Mm-hmm. So if you can make sure people understand that all they need to do, well, not all they need to do, but they need to start getting areas of the body starting to get back into fun, meaningful activities, things gradually then will start to alter and change for the better. It's solutions, not problems.
As you say that, Mike, I guess one of the things I think about is, we don't have necessarily great visual maps of our back because we can't see it directly. And the same could be said for pelvic health. We don't really have good visualization of our pelvic floor. And so, if our brain needs to see us doing something in order to really kind of get that it's okay, it's safe, how much of that might be because we don't have these visual sort of inputs, do you think?
Oh, I definitely think so.
Yeah,
I think you need as much feedback as possible. This is why, you're working out in front of a mirror, you've got some feedback. You can see how you're walking, running, exercising. So I think now's the time to start turning people's cameras on their laptops and iPhones. And, I always love it when the patients who I see drive things change in practice that I've not considered. We have patients all the time who say, look, this was me 3 weeks ago. This is me today. So if we're talking about behavior change, what makes people buy into a diet is the before and after shot in the magazine. So again, to prove to your patient that maybe they can do more than just manual therapy. Make them see it. They have to see that there's a change. If they change their behavior, then they'll change their action, their motivation, their everything about their movement.
Mm-hmm.
Yeah. Seeing is believing.
Seeing is believing.
I think it could even be fake seeing, because when you just said that, it reminded me of when because I had become very hypervigilant around movement and very obsessed with like biomechanics and that sort of stuff. So I started training my homunculus. I imagined this little person in my brain, and that I was remapping my movement through my brain rather than focusing on what my body did. And it was incredibly helpful, and it sounds super weird, and everyone's probably thinking that it's super weird.
Do it all the
but
time.
It was incredibly helpful, and that visualization, I think, also helped me to have a more accurate, I don't know if that's the right word, representation of my body, which had become, because my perception of my body had become totally skewed. Even just sensory perception in my leg was totally off. Like I couldn't feel my leg for a good year.
Mm-hmm.
So those things were incredibly helpful, and that's very scary stuff. So when people are just saying to move more, but you can't feel your leg, you don't know if your foot is touching the ground, moving more can be a really scary thing. So going into why people aren't doing things, and that it might not just be motivation, it might just be a really frightening thing. And what's done in the clinic or what's done under supervision doesn't always translate into people's real lives. So I think you've touched upon that too, it needs to be meaningful in their lives too, and they need to be able to do it in their lives, and not everything that's done in the clinic transfers over. Which I know we're getting away from education and talking about all that kind of stuff, but it's part of that education process too, and helping people to understand why this is beneficial.
I don't think we are. I think what the topic we're really touching on here is never underestimate how much people can understand, how much they can, if we act really as a key. If you can unlock something, if you can get people starting to realize that actually, okay, there isn't a right or a wrong. We spoke last time about in education, there's this idea when you're new to something that there's a very black and white binary, right, wrong. I should move like this. I shouldn't move like this. Actually, it's more nuanced than that. And I always say to people that we use a rubber stamp of approval, that idea of like a passport control officer to say, you're safe to move, but the way you move really doesn't matter. I mean, that's an uncomfortable thing to say as a physiotherapist. I trained in movement, but the more I sort of work with complex persistent pain, the more you realize, does it really matter if you're doing a level 3 clam or from your brain's point of view, it just wants to see function. It just wants to see meaningful, fun movement that means something, I think that's the key thing.
And movement variability.
Yeah, exactly.
Yes.
Variety and changing it and making it different, right? Why do you have to do it that way? You don't. Like, have you tried it some other way? And what happens when you try it some other way? Did you fall apart, or hey, was it all right? And that's okay, right? Like, I think sometimes we just get so hung up on the proper way of doing things. And I think that also can lead into other problems or other issues, right?
That's it. There's no right. There's no wrong.
I can't bend that way, or I can't squat that way because my knees are going over my toes, and that's terrible. And like, well, is it really?
I see it all the time. I have students often who come to courses, and they'll obviously they're trained in manual handling, and they'll say, but I can't tell people to bend this way. They have to bend this way. I'm like, well, where's the evidence for this? Look at it. I always think about evolutionary biology. If you look at a giraffe or a squirrel or a badger, or you don't see them bending in sort of, a very careful, methodical, thoughtful ways. They just bend. So like it or lump it, we're animals, so we need to just behave like an animal behaves, just move.
I think as well that this time frame kind of gives us an opportunity to really make sure our patients experience the changes for themselves as well. That's not something we do to them, So it's interesting. My daughter, who's a physiotherapist, had a patient this week who she's like, Mom, if she was in the clinic, I would have done some work to desensitize her post-perineal sort of postpartum scar that was tender, and that's why she wasn't having intercourse. But she's like, she was on the phone and I just walked her through doing it herself. And all of a sudden we were starting to have a discussion about how she hates the scar and how it just doesn't feel right to her, and how the whole emotional piece came out because she was doing it to herself, right? She was empowered to touch it and to experience it. And Brittany was walking her through that on the phone. And she's like, that was a really big aha moment around really connecting, getting the patient to connect to themselves again, not us connecting to them. Because there's nothing, her scar was 8 months postpartum. It was healed. There was nothing that Brittany had to do to fix it. It was just sensitive, right?
But it's that moment, you know, I often joke with clinicians, lots of clinicians have had the moment where you're in a consultation with a patient, they're just about to leave, and as they're about to leave, they drop the bomb. They say, "Oh, thanks very much for seeing me today. I think I have Parkinson's. Thanks." But you know, they're sort of, they walk out the door as they drop their huge amount of anxiety or distress. Right. We now find ourselves forced into a situation where those moments might come to the surface more often because there's a social distance. Mm-hmm. I've certainly found personally that over the years of seeing people on Skype and Zoom, it's easier in some ways from a communication point of view because you're forced to think about these skills.
Any other questions? I'm going to pick on a few people I know. Anna, Nicole. Sorry, someone spoke up. Go ahead. Yes.
Sorry, Eva.
Hi, Eva.
Hi. So kind of going off of the previous conversation, I've run into some difficulties myself when I'm talking to patients with more persistent pain, and you know, getting them on a kind of goal-oriented program and doing really well for the first couple of sessions. And then sometimes when I try to maybe push the pain education conversation, I don't want to say push it, but have a little bit more of an in-depth conversation, a little bit about maybe the anatomy, or perhaps tying in other stressors into that conversation. And then all of a sudden something happens and the patient gets a little alarmed, and then I kind of see them shift and they don't feel so comfortable. So I'm kind of assessing their readiness to have that conversation, and I don't know if I misjudged them, but we're doing really well. Great report. They're meeting all of their goals. They're progressing fantastically from their own perspective, and then all of a sudden we push the boundaries a little too far, and then either I don't see them for a little bit, I have to reach out to them and say, hey, what's going on? And you know, it kind of like not falls apart, but doesn't go as planned.
So what you're saying is that the therapeutic alliance is building, and then you sort of maybe from your own judgment, maybe take things a little further than they're ready for, and they drop away a bit.
Mm-hmm.
Yeah. Why do you think? Because that's an interesting point, and it's something that I've certainly seen. Why does that happen, and what do you need to do to change it, would be my two questions. I'm always one of these horrible educators where I learned the sort of Socratic way of trying to ask questions to get people to think about that. So why did that happen, and what would you do differently?
Yeah, so I've always kind of, there's one patient that's kind of just stuck with my mind, and I always kind of go back to that that particular incident where I definitely thought back and I thought, did I appropriately read what she was telling me and her level of readiness, right? Because she was very receptive to everything we had talked about previously. We did have, as you had put, that therapeutic alliance. She was getting a lot of relief and a lot of this pain relief that she had that was persistent, but there was that little maybe gnawing, a little bit of pain that persisted or came back or something. And I think I was trying to, as you had put earlier, like paternalistically trying to get rid of or eliminate all of that pain, right? Like it's a 100% pain relief or something of that nature. And now I think, well, was that realistic of me to think that she would have 100% pain relief? Was it my goal and I was putting it on her?
Yeah, it's a very good point. It's again, if you're using the metaphor, the analogy of the parent, This happens in parenting all the time. You sort of, you start to lecture without meaning to the child a little more, and all of a sudden the child starts backing off, and it's no different. So I would suggest, first of all, don't beat yourself up, because I've done it so many times, and I'm sure everybody listening to this has. It's, remember what Stephen Hawking said, that this stuff is too complex, too uncertain, too unpredictable. That's why he decided to study black holes rather than medicine like his father. So always remember that, because I think sometimes I certainly do. I beat myself up all the time if I get something wrong. But I think, in a way, sometimes these sort of experiences where you recognize something's gone wrong, they're actually the best experiences, because if you really reflect on them, you can start to change your practice. So what do you do differently in future? What have you learned from that experience?
That's a great question. I think I'll have to reflect on it.
That's the point. I think one of the issues is that I teach sort of second part courses, normally like 1 year after we've had a group of people together, and it's very reflective. We do this sort of thing. What would you do differently? I don't teach people. I ask them questions. I get them to reflect. And what's always interested and fascinated me is you get a room of clinicians together to reflect on their experiences, and particularly where they've gone wrong. You learn so much in the same way that patients do if you ask them to reflect on what could you do differently next time. For example, I love it when I have people who come in and they've had a flare-up and they're in agony, and they say, oh, I went in the garden for 4 hours, and I always go, great. My initial response is great. They're like, well, I'm in pain. I go, I know, but you've done something. You've had an experience. What are you going to do differently next time? What have you learned from this? We don't learn from experience. We learn from reflecting on experience.
The other thing that I observe, Eva, when you say that is, and I hear this a lot when I'm teaching clinicians and stuff as well, is why is it that we remember the one who didn't do well, and we don't think at all again, especially when it comes to pain education. I think when it comes to our hand skills, we remember all the people we helped. But when it comes to our pain education skills, we remember the one person that got turned off by our pain education. And we forget the 25 people who did really well with that information. And it's very curious how those two tools in our toolkit, we behave very differently with. I don't know if anyone else has had that experience, but I hear that a lot, that one experience. I'll never do that again because that one person didn't do well with it.
Very much so. Sometimes I meet people who say, I don't see people who have these problems in my town. And then I've had times where there's been two clinicians who work together in the same practice, and one will say, well, this doesn't happen where we are. And the other one will say, yes, it does. You choose not to see it. So I think that, it's acknowledging the complexities of what we do, but also acknowledging the fact that you're not always going to get it right. Put it down to experience and change from the experience.
So proactive plus physio, someone has a question. Go ahead and ask your question. I just see the name of the clinic there.
Hi, Carol. This is Deepa here. How are you?
Hi, Deepa. How are you?
I'm good, thank you.
Awesome.
So I have a question just in relation to what you guys were just talking. You said, yes, this client went to do gardening and then they were there for 4 hours and then went. That's where I usually get stuck. Some of my clients, they ask me, yes, I did this, but then I think I overdid it. They ask me, when should I stop? I think that's where I get stuck.
Really good point. Really good point. We always try to use a sort of mantra. I sometimes feel like a game show host where I say the first part and the patient then says the second part. It's a bit collaborative. Rather than the old-fashioned no pain,
no gain.
No gain. Yeah.
To it, not through it. So if you guide people to a point where you say, look, are you working hard? Do you feel like you've got a bit of sweat on your forehead? Do you feel like your heart's pumping a little bit? Do your muscles feel like they've been working? Great. Then that's it. Stop. To it, not through it. And note the way that we're not using the idea of pain as an indicator. The worst thing you can do with that is to say to the pain, not through the pain, which of course will make people go, pain. It's one surefire way to make people worse, and it's to get them to keep focusing on their pain. Focus on function, focus on movement.
Okay. Thank you.
I have a question about that.
Yes, please.
So what you just said, like work to the pain, not through it. So
no, not pain.
Nope.
Pain out the equation. To
Function.
that point where you feel like you've worked hard.
Okay, to the point of effort. So I'll tell you something that I've tried before. I want to know if, I don't know, it's good or not, whatever. So I would sometimes ask, let's say they say I took a walk, let's say I did too much, and so I say, when did the pain start? Let's say it started about 8 minutes. I say, okay, next time I want you to stop at 6 or 7. Like, would that, like, and so sometimes I feel that I'm bringing down the level, like I'm telling them to do less when they want to do more, but at the same time, I'm like, I don't want them to keep on acknowledging that there's pain associated with their walks.
Great point. Do you know what I tend to do, and I found it can be very helpful for some people, is we spoke last time about how, can everybody still see and hear me?
Yep, absolutely.
I had a message on my screen saying internet disruption.
Okay, yeah, no, you're good.
What I tend to find can be very helpful, we spoke about how metaphors can be helpful. So getting people to think in a different way, not thinking about paced rehabilitation. And this again came from advice from a patient of mine in the past. Get people to start thinking about how people climb mountains. How does a mountaineer get to the top of Everest? Some of the people who I see who do best with rehab, they watch YouTube videos on how mountaineers acclimatize. And what they realize through watching those videos, it's far more engaging than talking about load tolerance and tissue loading. That bores the pants off people. But if you start to think about, how does a mountaineer get to the top of a mountain? Ask that question to people. Some people will automatically say, they get a helicopter. No, they don't. They go up. And then ask them another question. What happens when they get to the point where they're starting to struggle? When they start to struggle and they can't breathe and they feel like it's hard, what do? They go down a bit. It's about that process of you have to go down a bit to go up. So I would advise, personally, I find that getting people to think about the mountaineer or watching YouTube videos on mountaineering can be really helpful. There's some really useful tutorials on how to climb a mountain. It can be really helpful.
Going to take one more question if anybody has one more. Mira, go for it.
Hi everyone, how are you?
Good, Mira.
I know this is a very deep question regarding the pelvic floor. When we treat pelvic floor, my first question is about always constipation, huge. And I have 2 patients so far. When I said, we're just I know I cannot treat the constipation, but I can educate about the constipation, how pelvic floor is related. But then don't worry about my constipation. I have been having this 15 years. Don't worry about my constipation at all. And I'm like, if the muscles are super tight, I explain them, this is what's going on. Muscles are very tight, they need to relax. But they just don't show up for the next session. How this is very struggling point at me, because ideally, it's constipation. First session is always my constipation if they have it.
Okay.
But then how do you tackle it?
We're not going to ask Mike to answer that question because Mike's like, that's probably not my skill set, but I'm going to get Susan to
sorry,
jump in.
Mike.
No, that's okay. I'm going to ask, go for it, Mike. Yeah, go for it, Mike.
It might work. I don't know. It's not my field of expertise at all. But again, from a metaphoric point of view, one metaphor, if you're talking about tension, one metaphor that can often help is I ask people a question. What do you do if you've got kids, or even for people who don't have kids, who look after other people's kids, or I don't have children, but I've got godchildren and nieces and nephews. What do you do if your child that you're looking after goes to run for the road? What's your initial response if a child that you're in charge of, you're in care of them, what happens if they run for the road? What do you do?
Stop them.
You stop them, you grab them, you
grab, protect them.
You protect. So in essence, if you're talking about protection, we can use that metaphor of protection, because that's essentially what the nervous system is doing when it's contracting, when it's a protective response. So if you're talking about protection and tightness and stiffness and tightness, that's a really nice way to talk about it. You know, what did you do to eventually allow your child to keep going without pulling them back all the time? Well, gradually, slowly, I started to let them move again. So that the relationship between the brain and the body is a little bit like the parent and the child. It's that sort of tension, protective response. So that, sorry, that's my 2 pence worth.
I think that's brilliant.
That's exactly that's exactly how I approach it, Mike. Exactly.
Yeah.
It's the overprotective kind of response. And, you know, but the other one is back up a little bit further as you're listening to their story. And I just get curious when they say to me, don't worry about my constipation, I've had it for 50 years. I say, can we back up a little bit? Tell me more about that. When did it start? You know, what have you done for it? What's happened? What hasn't worked? What do you know about it? What do you believe about it? And what do you expect? And then you start, because then you're getting their story, and I'm getting curious about their story. And I'm allowing, like Mike said, draw it out. And then you can just kind of space hold that. You don't have to, you can't be constipated and then walk out the door. But you're planting the seeds that maybe something can change about this. Maybe what I've been thinking about this all along was this, but maybe there's more to think about with it. And you're opening the door and allowing them to kind of start to bring it up to their consciousness and explore it a little bit without, as Joletta says, cover their narrative or their story with your own.
Okay.
I love that. I love that, Susan, because it might be something that they thought could never change. And if that's not the problem that they're seeking you for, I love that Eva brought up that wonderful self-reflection question of, is this my goal or theirs? And going from that, because if it's your goal to relieve their constipation and not theirs, there's going to be resistance and conflict there. But planting those seeds, and it can be one of those things that they've written off. This is never going to change. I've had it my whole life. It's going to take some time for that belief to change, and that's not going to happen for most people right away.
Okay. Thank you.
Great question.
And I just wanted to add too that I loved that question, Eva, about is this my goal or is this theirs? I think that's such an important one for me to revisit all of the time too when I'm talking to people about their experiences, because I have a tendency to want to tell people what I think is going to help them because I want them to do that, not because they want to.
Yeah.
I think with that in mind, I think it's a really good question to ask people, Gilletta, which is, you have some choices, you know, let's go through your choices. So it's their choice. As a clinician, the worst thing to do is to say, I think it's best for you to do this. I would always approach it like a journey and say, you have several options now. If we're now at a junction, you have different ways that you can go. And each way has a consequence. You know, that each action that you take has a consequence. So if you do too much, for example, if you are the no pain, no gain type person, there is a consequence to that. Often it's not damage, but it's sensitivity, and sensitivity that keeps repeating and becomes better. If you do nothing, then there's a consequence to that too. So that it's being non-judgmental, but giving people the options. And they're their choices, not ours.
I love that, and I've really come to the point where I don't create problem lists with my patients anymore. I create opportunity lists, and then I say to them, "And where would you like to start? Which opportunity would you like to start with?" Because then it becomes theirs. They own it, and they, you know, compliance goes way up. That's what they've chosen at that point, right?
I love that so many of our themes over the last few projects keep coming back to like curiosity and exploration.
Yeah, absolutely.
Get curious about what's possible and then explore those possibilities.
Yeah.
Add that reflection piece to that, not only for ourselves, but for our clients.
Yeah.
Give them the opportunity to reflect on what didn't work. And on their journey, you know, if they can reflect back on their journey, oftentimes they come up with incredible insights as to maybe where things went wrong and where things got derailed or what's happened, and they just haven't really had the opportunity to reflect on it. they know their story, they can tell you their story piece by piece by, you know, step by step, and then this happened and this happened and this happened, you know, we could get that. But what about the reflection piece? And when they have that opportunity to reflect, all of a sudden, you might be so surprised what kind of insights they come out with. I have been just like amazed. It's like, wow, listen to that.
I think so. You know, I'm a huge fan of a quote, and I so often use quotes with patients. So when, you know, quite often people will say to me, but if I start asking my patients questions, they'll often respond with, well, you're the expert, you tell me. Of course, you're the expert. You know, you will know you far better than anyone else will ever know you. I often use quotes, and they can be really helpful. And again, it's in a non-judgmental way. Socrates once said, to find yourself, you must think for yourself. So, you know, E.M. Forster once said, spoon feeding in the long run teaches us nothing but the shape of the spoon. So, you know, the spoon for many people for years, I've seen many people who've spent 20, 30,000 pounds on being spoon fed manual therapy or electrotherapy or Pilates therapy, or, you know, can we help people to become more independent? And I think now is a great time to do that. As bad as this situation is, it's going to force us to start to look at self-management.
Excellent. Susan, do you want to wrap up? Thank you so much.
I would love to wrap up. Thank you so much. And my sincere gratitude to everybody who came on to join us today. I do believe that when we get together like this, good things happen. And being able to share in this particular time of human existence for us is, I think, key to all of us really feeling connected, feeling closer, and feeling like we're part of the change rather than you know, part of the problem. And I love that. So thank you, everybody. But from Gilletta and Carolyn and myself to Mike, this has been a complete honor and privilege to have you on with us. And I know the three of us have learned so much, but I know that everybody else has benefited from watching your videos with us and from listening to you today. And we will put in the show notes where you can find Mike Stewart at Your No Pain Mike. And he's on Twitter, he's on Facebook. He has his great website. He has wonderful courses, and some of them are online. Is that correct, Mike?
Some are online, yeah.
Yeah, all online. So
yeah.
This time of, you know, when you've got maybe a little bit more time on your hands or not, since you're not commuting right now, might be a good time to pick up one of his courses and learn how to start drawing things out of yourself and your clients at this point. So we'll put that information in the show notes on that when we publish this on YouTube and on our website. Carolyn, anything to wrap up here?
I would say that for anybody who has not taken Mike's course on Embodia, right now, March Madness, it's almost the end of March. His course is 50% off. This is a great time to actually do that. I just listened to it myself, and it was a fabulous, very insightful course on learning how to be better educators. So I would encourage you to do that. Thanks, Mike. Thanks for joining us for both sessions.
It's a pleasure. I said I like quotes. Noel Coward once said, work should be more fun than fun. This is not work for me, especially with Jack Daniels on a Friday night.
Yes, right.
That's right. There you go.
So cheers to everyone. Thanks for joining us. And our next project we will announce shortly is going to be on peer support, I believe. And Gilletta's really excited to be kind of leading that one a little bit more. So, all right.
Keep up the great work, you three. You're doing really good. It's great. It's really nice to have this nice mix and different ideas. And so I think you're doing really well. This is more of what's needed. I was talking with a French colleague of mine today, and we were talking about how reflective practice is needed more. So this is ideal.
Awesome. Thank you, everybody.
Thank you.
And best over the next couple of weeks.
Yes.